Allie Cronley. Anna Warhite. Cindy Seeley.
Hi, this is Cindy. Good morning.
Hi, good morning, Cindy. Neil Brady. Gail Weidman. Herman Perotti.
Who do you have?
Ashley Simon.
Here. Good morning.
Hi, good morning, Pesci. Jay Harner. Juanita Gray. Kyle Glozier. Laura Lyons is excused this month. Lloyd Wirtz. Matt Seeley. An alternate for Monica Vaccaro, Melissa DeHoff. Melissa, are you present?
She would, if you can.
I see. Patricia Canela Duckett.
Good morning, everyone. Hopefully you can hear me.
We can. Good morning, Patricia.
Thank you.
Sherry Welsh. And Tanya Teglow is excused with an alternate, Carrie Bach, attending via webinar. Are there any other subcommittee members that I missed that would like to announce themselves?
Good morning, Jay Harner is present.
Hi, good morning, Jay.
Good morning, this is Anna Warhite.
Hi, Anna, good morning.
Good morning, this is Allie Cronley.
Good morning, Allie. And
Good morning, this is Ellen Joyce in place of Noah Gifford.
My apologies. Could the last person reintroduce themselves? I don't recognize the name. My apologies.
Yeah, no worries. My name is Ellen Joyce, Joyce, and I am with Alert Medical in place for Noah Gifford.
Noah Gifford.
Noah?
He's not a member, but he comes and sits in the audience. So.
Understood. My apologies for speaking with my colleague here in person. Thank you for joining, Ellen.
You're welcome.
And Lloyd Wirtz is present in person. Is there anyone else that I missed that would like to announce themselves?
This is Gail Weidman with PHCA. Good morning.
Hi, Gail. Good morning. I thank you all for attending on this July 6th. Excuse me. I'm going to hand it over to my career for housekeeping.
Hello, everyone. Thank you for being here today for our July 6th MLTSS meeting. Before we get started, I do want to thank both the OLTL staff and David for kind of supporting me through these last couple months. I had a few things happening in my life, so they stepped in more than amply. Let's put it that way. So I thank all you guys for the support. Let's get to the housekeeping talking points. Please keep your language professional. This meeting is being conducted in person at the Department of Education's Honor Suite as a webinar with remote streaming. The meeting is scheduled till 1 p.m. to comply with logistical agreements. We will end promptly at that time. All webinar participants, except for the committee members and presenters, will be in listen-only mode during the webinar. While committee members and presenters will be able to speak during the webinar, to help minimize background noise and improve sound quality of the webinar, we ask that attendees to self-mute using the mute button or mute feature on your phone, computer, laptop, when you're not speaking. To minimize background noise in the honor suite, we ask the committee members, presenters, and audience members in the room to please turn off your microphones when not speaking. I also should remind everyone that this meeting is being recorded. Your participation in this meeting is your consent to being recorded. The captionist is documenting the discussion remotely, so it is very important that people speak directly into the microphone, state their name, and speak slowly and clearly. Please wait for others to finish their comment or questions before speaking. This will enable the captionist to capture the conversations and to identify the speakers. Please hold all questions and comments until the end of each presentation. Please keep your questions and comments concise, clear, and to the point. We ask the webinar attendees to please submit your questions and or comments into the questions box located in the GoToWebinar pop-up window on the right-hand side of your computer screen. To enter a question or comment, type into the text box under questions and include the topic to which your question or comment is referring or referencing and press send. Those attending in person who have a question or comment should wait until the end of the presentation to approach one of the microphones located at the two tables opposite the speaker. The chair or voice chair will then call upon you. Before using a microphone in the room, please press the button on the base to turn it on. You should see a red light indicating that the microphone is on and ready to use. State your name into the microphone for the captionist and to remember to speak slowly and clearly. When you're done speaking, press the button at the base of the microphone to turn it off. The red light will turn off, indicating that the microphone is off. It is important to utilize the microphones placed around the room to assist the captionist in transcribing the meeting discussion accurately. There will be time allotted at the end of the meeting for additional public comments. Webinar attendees should enter questions and comments into the questions box and include the topic in which your question or comment is referencing. We want to remind everyone that this meeting is a place for general information and questions about OLTL managed care. Questions and or comments of a person or individual nature will be redirected to the appropriate people to follow up. To follow up. Responses will be sent directly to the individual asking the questions, and if you have any questions or comments that weren't heard, please send your questions or comments to the resource account identified at the bottom of the meeting agenda. Transcripts and meeting documents are posted on the MLTSS meeting minutes listserv. These documents are normally posted within a few days of the meeting. The 2023 MLTSS Subcommittee meeting dates are available on the Department of Human Services website.
The following are emergency evacuation procedures. In the event of an emergency or evacuation, we will proceed to the assembly area to the left of the Zion Church on the corner of 4th and Market. If you require assistance to evacuate, you must go to the safe area located right outside the main doors of the Honor Suite. OLTL staff will be in the safe area and stay with you until you are told you may go back into the Honor Suite or you are evacuated. Everyone must exit the building. Take belongings with you. Do not operate cell phones, and do not try to use the elevators as they will be locked down. We will use stair 1 and stair 2 to exit the building. For stair 1, exit Honor Suite through the main doors on the left side near the elevators. Turn right and go down the hallway by the water fountain. Stair 1 is on the left. For stair 2, exit Honor Suite through the side doors on the right side of the room or the back doors. For those exiting from the side doors, turn left and stair 2 is directly in front of you. For those exiting from the back door exits, turn left and then left again, and stair 2 is directly ahead. Keep to the inside of the stairwell and head outside. Turn left and walk down Dewberry Alley to Chestnut Street. Turn left to the corner of 4th Street. Turn left to Blackberry Street and cross 4th Street to the train station.
Thank you, David. We're going to move on to the MLTSS. I'm sorry, go ahead.
Excuse me, Mike. Good morning, Jeff. Are you subbing for Matt Sealy today?
Yes.
Thank you.
Thank you, David. We are going to move in the agenda to the MLTSS meeting follow-ups from June 1st, 2023. Related to assisted living AL in lieu of services, audience member Margie Zelenak stated in the chat that there is a discussion of AL services under ILOS. She wanted to know if this has been approved. Juliet to provide a response.
Juliet responded that discussions are ongoing.
Multiple questions were asked during the June meeting about adult protective services and the role of area agencies on aging in the ombudsman and guardianship. OLTL to respond.
Hi, this is Paula. Because the AAAs are under the Pennsylvania Department of Aging, OLTL staff have reached out and are coordinating with PDA to determine when they can present to the MLTSS subcommittee on the questions OLTL received related to protective services, guardianship services, and ombudsman services. Other questions on the same topics were directed to the OLTL Bureau of Human Services licensing. The questions and responses will be available on the MLTSS listserv within a few days after this meeting.
Related to home care agencies, audience member Pam Auer asked, with such a deficit of direct care workers, why are so many managed care organizations not taking on new home care, are not taking on new home care agencies if they're coming up, excuse me, let me start over again. Why are so many managed care organizations not taking on new home care agencies if they're coming up and are able to staff some of the people who need this, who need the help? Why is there not more? We have been talking month after month after month about how desperate we are for people to fill hours. This was to be readdressed during the public comments. However, time ran out. All three community health choices, CHC MCOs requested to provide the response.
This is Paula. AmeriHealth Caritas Keystone First responded that they currently have over 1,000 personal assistants and that they have met their network adequacy. PHW responded that they continue to remain open in Beaver, Butler, Crawford, Washington, and Westmoreland counties. Their decision to not add more home care agencies in the Philadelphia area is based on the current volume. There are over 600 agencies that support the Philadelphia area. When PHW encounters a staffing challenge, it is not due to a reduced network, as much as it is the choice of many providers to not accept referrals needing fewer than 8 hours a day. They also see cases whereby the participant only wants a specific type of worker, for example, female, size, age, ethnicity, and refuses available direct care workers that a provider may have. If there is a specific case that is in need, PHW would be happy to take a look at the case and identify a provider that can support the participant. UPMC responded that they have a network of over 1,400 PAS providers. They are actively engaged with these providers and are working to better understand capacity and quality within these organizations. MCOs require full-time equivalent reporting of direct care workers for participating network home care agencies to monitor, in part, capacity of the then current network. Additionally, the UPMC service coordination and network teams have an ongoing collaboration to identify areas, zip codes, and counties with diminished capacity and work within their network providers to close gaps. If the existing network cannot support gap closures by hiring additional direct care workers, the network will be expanded if new home care agencies can staff these identified areas. The addition of a new home care agency only guarantees the addition of an administrative entity to the MCO's network, not actual direct care workers. And finally, UPMC recognizes the importance of participant-directed services as an essential alternative to agency-based models for service delivery and participant choice, and wants to expand this option in the future.
Thank you, Paula. And we do know that there were other questions that are answered on the listserv, and you're free to browse that as well. We're going to move on with the agenda to the Office of Long-Term Living. I don't know if this is Julia or Randy.
Good morning. This is Juliet. I apologize for having to participate remotely. So Randy and I are going to tag team this. I think hopefully Randy's there in person. So can folks hear me okay?
We can hear you great, and Randy is here.
Wonderful. Thank you. Thank you, Randy, for being there. So if we can go to the next slide, I'm just going to go through the agenda. I will be handing it over shortly to Randy to kind of walk through the rest of the updates. But based on sort of the interests of the group and things that we've received, we're going to talk a little bit about the listening session, the CHC RFA, PHE unwinding, and the nursing facility rates. But before we get into that, if we go to the next slide, we did want to formally recognize and congratulate Secretary Val Arcouche on her confirmation. And so very excited that that has been confirmed, and looking forward very much to working with her as our Secretary for the Department of Human Services. And then the second update that I wanted to touch on briefly, as many may have known, we are still waiting for approval for the fiscal year 23-24 state budget. The Senate did pass a common sense budget bill. However, we are still waiting for the House to review, approve, and pass their counterparts to that. So what that means is that, you know, we hope that this won't be a sort of long and drawn out process. You know, we do look forward to getting that budget passed, but we are certainly at this time kind of in a waiting mode. So wanted to give that update for folks today, just so that folks were aware where we stood with the state budget. And then with that, those updates, I'm going to hand it over to Randy to go through the following items.
Thanks, Juliet. Hi, folks. This is Randy Nolan from the Office of Long-Term Living. A couple updates on the statewide listening tour. We started the tour. Juliet made visits on June 5th and 6th with the SIL, AAA, and life providers in Erie and Pittsburgh. Gained a lot of information from that. As I said, we're continuing to schedule dates to go out. A listserv message was released on June 15th. To outline and ask for assistance of providers in putting on these sessions. We're also scheduling some virtual sessions. We have 3 scheduled right now for July 19th, 21st, and 22nd. That information should be in a listserv if people want to sign up for it. And then we're doing additional in-person sessions around the state between July 11th and August 19th. So we'll be up in the Scranton area, we'll be down in the Philadelphia area, we'll be in Central PA, Lancaster, York area, Williamsport, and we'll continue to take a look at some other sessions out there. There is a flyer that has all the available dates on. It's at the website, CHC Communications to Participants on the DHS website. So that should give you all the locations, times of the listening session meetings. We encourage people to come out to these sessions. We encourage providers to help participants get out to these sessions. We want to hear from the participants on what they're seeing in the program, what they would like to see changes in the program, what ideas they have, or just ask questions of us while we're out and about. So this is an opportunity to really get individuals out there. So, please, help individuals out there, work with the MCOs, get transportation set up. We like to see a lot of participants at these meetings. All right, so on the next slide, we'll give you a little update on the CHC request for application. We're currently going through and have gone through the comments in the RFI. We have a number of work groups that are working on looking at those comments and incorporating them into the language for the RFA document, and that will go out. So we continue to do that. A summary of the comments received, we're posting them on the CHC website for review. We didn't post all of the comments, but we posted the broad categories that the comments kind of fit into. As far as timelines with the RFA, we don't have at this point, a set timeline. As things become more clear of when we're going to release the RFA and other information related to that, we will keep the public updated on that at these meetings and also on our website. So that's the big project right now that we're working through, is the reprocurement of the program. For PHE unwinding, we continue to monitor this. We have a number of individuals who were closed out because they didn't return the required documentation, even though they may still be eligible. So what we've done is we've sent a list out to the MCOs to follow up with those individuals to try to determine why they did not submit their paperwork, whether they moved, whether they moved out of state, whether they ceased, or whether they just don't want the program, or they know that they're not going to meet the eligibility requirements of the program. But we want to find out with those individuals that didn't submit the paperwork, the reasoning behind it, and encourage them to submit the paperwork. So we're providing that information out. There's some numbers in here, over 800 individuals that we're following up on. So we will continue to work with the MCOs to follow up with these individuals. All right, next slide talks a little bit about the 2023 nursing facility rates. We released a listserv at the beginning of the month about the proposed fee-for-service rates. The department noted that there's some variance between the April 1st rates and the July 1st rates that seem to be a little bit greater than in previous years. There's always variances with the rates as they change from quarter to quarter, but we're seeing a little bit more difference this time around. The July audited cost reports include a year of increased COVID-19 related costs, which impacted the average fee-for-service rate. The first year of COVID cost experience entering the current rate setting year have led to some unanticipated swings in individual provider rates, and we're probably going to see that again next year as we still deal with COVID-related experiences. To make a change in that, though, and look at that in a different way, we would have to have direction from the General Assembly to amend the rate methodology, and we would certainly support that resolution if something like that came up, so that we can ensure that the swings in the rates aren't as great as they currently are. The proposed rate notice was published in the PA Bulletin on June 24th. We currently are working with the nursing facility and their associations and all stakeholders to review the July 23 proposed rates. They are subject to change. Obviously, they're proposed at this point in time, and they can change depending on further review. And then we get a picture of me with my blank stare.
Randy, I do have to hop in a second and amend my statement about the budget. The House did pass the budget last night. Thank you, Andrew, for bringing that to my attention and letting me know I needed to update my statement. So our team will be looking and diving deeply into seeing what has passed and what that means for us. So apologize for that. Just wanted to make sure that my statement was corrected. And thank you, Randy, for the presentation.
Thank you. Are there any questions? Any questions online? I'll be here until I have to leave at 12:30, but I'll be here to answer any questions that come up later too.
Lloyd?
Thank you. The PHE unwinding numbers, was that for the first month of the revalidation, or was that up to date?
I believe that's up to date numbers as of probably last week, so the end of June.
Okay, that's good enough today. Thank you. Second question is, when CHC was first established, the decision was made that there would be 3 managed care organizations that would handle the service delivery and contract with the state to perform that. Is that still the number that's in mind, or is there a possibility of expanding that or contracting that?
Yeah, originally when we did the program 6-7 years ago, the way it was written in the RFP at that time is that we were looking for 3 to 5 managed care organizations to look at the program. As we went through the process and evaluated the proposals that came in, the final decision that we went with was to have 3 statewide vendors. Same type of thing's going to happen this time around the RFA. It's going to have the same language in 3 to 5. There may be more, there may be less. You know, there's always a possibility to look at regional versus statewide. So there's a lot of things that will go into the final decision once we have all the proposals in and reviewed.
Any other questions for Randy, OLTO?
I have an item in the chat.
Go ahead.
So this is from Cindy Sealy. Randy, she's asking, are the PHE unwinding numbers specific to HCBS participants?
We'll have to check back on that and get you an answer, because I'm not sure if it's just HCBS or whether it was nursing facilities. So we can check on that.
Thank you, Randy.
Anything else in the chat, Paul?
That's everything, Mike.
All right. Any other questions for Randy or Juliet? Thank you, guys.
Thanks, folks.
We're going to move to the next item on the agenda. It's the Pennsylvania Medicare Education and Decision Insight MEDI by Keisha Herman, PA Department of Aging.
Hello. How's my audio? Is it okay?
Great, thank you. We can hear you
All
well.
right. Okay. Thank you so much. Good morning, everyone. Thank you for the opportunity to present today. My name is Aikisha Hermanton, and I am the PA Medi statewide coordinator. And also with me is Susan Neff, the PA Medi director, and she will talk a little bit later. We are from Pennsylvania Medicare Education and Decision Insight, PA Medi, Medicare counseling program that is managed by the Pennsylvania Department of Aging's Education and Outreach Office. Today we will cover what is PA Medi, how and who does PA Medi help, and how do we promote PA Medi. Next slide, please. Let's start with a quick question to get things started. I understand that I probably can't see the chat, but if you guys want to answer the question there in the meeting in person, or if there's any responses in the chat, then that's fine. Or if it's quiet, then that's okay too. So the question that I have is, how many people living in Pennsylvania are eligible for Medicare? Any guesses out there?
I think Lloyd Wirtz did have a guess, but I don't think it hit the microphone.
Is it ballpark of 12.7 million?
That's a good guess, and I will give you points for saying million. Next slide. You overestimated though. We have 2.7 million Medicare beneficiaries in Pennsylvania. So credit for the million part. Good job. Thank you. According to the last U.S. Census in 2020, Pennsylvania ranks 5th nationally in population for people ages 65 and over. And we rank 3rd in what we call super seniors, ages 85 and older. The aging population continues to grow and is predicted by 2030 that 1 in 4 Pennsylvanians will be over the age of 65. Medicare, hopefully everyone is familiar, but if you're not, let me just quickly explain. Medicare is a federal health insurance program that serves people ages 65 or older and certain people under age 65 with disabilities. The term beneficiaries that you see on the screen will be used frequently throughout this presentation, and in our case, it refers to someone who is eligible or enrolled in Medicare. You may also hear the term client or consumer. I know that you might be familiar with that already from the work and the services that you guys are familiar with or participant, but we mainly use beneficiaries in our population. So when you consider these numbers, 2.7 million, we have the 5th largest population of the folks 65 and over. The complexities of Medicare, if you do know anything about that particular program, it makes PA Medi and its services crucial to Pennsylvania's older adults. Next slide, please. So PA Medi is Pennsylvania's State Health Insurance Assistance Program, or SHIP, and it is a free service provided by the Pennsylvania Department of Aging. And as you see in our logo, you see what the acronym PA Medi stands for. Next slide, please. Now that you know a little bit about our program, let's talk quick about how it's structured. At the Pennsylvania Department of Aging, there are 2 positions funded by the grant. The PA Medi statewide coordinator, that's me, and the director, Susan Neff, who will talk later. The statewide coordinator makes sure PA Medi's mission is carried out through compliance with SHIP standards and by providing direction and initiatives to local programs. Next, there are 4 regional coordinators who oversee operations within their territory. They are responsible for the development, coordination, and presentation of training materials, plus much more. Local staff oversee their programs, recruit and manage volunteers, and conduct outreach, hold events, and ensure services are being provided to beneficiaries in their counties. Last, but certainly not least, we have over 350 volunteers to help meet the needs of our program by counseling, doing presentations, answering calls, etc. Although we have many volunteers, we are always looking for more throughout the state. We will talk more about who PA Medi helps next. Next slide, please. PA Medi serves Medicare eligible individuals. As stated earlier, Medicare is a federal health insurance program that serves people ages 65 or older, and certain people under the age of 65 with disabilities. Next slide, please. PA Medi's mission is to empower, educate, and assist Medicare eligible individuals, their families, and caregivers through objective outreach, counseling, and training so that they can make informed health insurance decisions that optimize access to care and benefits. So how does PA Medi help beneficiaries and carry out our mission? We offer free, confidential, unbiased, one-on-one, personalized Medicare counseling to the Pennsylvania's beneficiaries to assist them in making informed decisions about their Medicare insurance coverage. We can help beneficiaries compare available Medicaps, Medicare Advantage, and drug plans in their area to look for cost savings based on their own healthcare needs and circumstances. We also explain new benefits and annual changes to plans. Although counseling is our primary function, we also assist with other areas of Medicare. For example, if a beneficiary does not agree with a decision from Medicare or their health plan, the counselor can assist with appealing the decision. When a beneficiary selects a Medicare Advantage plan or a prescription drug plan, the counselor can also assist them with enrollment. We also provide help and enrollment assistance with Medicare financial assistance programs for those looking for ways to save money on their Medicare costs. This can be done through Medicare Advantage and drug plan comparisons, the Medicare savings programs that offer help with premium costs, program called Extra Help, and PACE, another program which can lower prescription drug costs. PACE and PACENet is a unique prescription assistance program for older adults offering low-cost prescription medication to qualified residents age 65 and over. And the program works with Part D plans and other prescription drug plans to lower out-of-pocket costs for medications. Extra Help, that program I mentioned just a few seconds ago, is the low-income subsidy program, and it's a federal program that's also offered here, which helps pay for the Part D premium and reduces out-of-pocket costs of prescription drugs. In addition to those functions, PA Medi can also explain the complexities of Medicare health insurance, the rules and notices that beneficiaries receive. We also explain the preventive services covered by Medicare because those are important for keeping people healthy, and they can also save money by reducing one's overall need for health care. We also address coordination of benefits and how various insurance options work together with Medicare. These other insurance options include employer group health plans, so the insurance program you may be in from your job, military, veteran benefits, and Medicaid. Lastly, for this slide, I want to mention that when a beneficiary calls or comes in for assistance, the PA Medi counselor may become aware of other issues or needs outside of our scope of service, but the PA Medi counselors are trained to provide some referrals to other needed agencies or services, such as LIHEAP, which is a heating assistance program, or SNAP, which is helpful to provide food for those who are in need and meet the criteria. Next slide, please. The ending of the COVID-19 public health emergency, or PHE, affected a lot of people and processes or resources that were in place for a few years. For example, the ending of PHE directly impacted people's status in Medicaid, and due to age-related factors, and in some cases, income levels, the Medicare-eligible individuals were impacted too. So PA Medi prepared for the end of the PHE by training our network and being knowledgeable about what was happening in our state and the available resources for the population we serve. Some things to know: if a Medicare eligible beneficiary lost their Medicaid, because of their termination from Medicaid, beneficiaries will now be responsible for their Medicare deductibles, co-insurance amounts, or their Medicare Advantage copays. However, if the beneficiary is still eligible for one of the Medicare savings programs, that benefit will remain. Also, beneficiaries will continue to have extra help if they were in that program to pay for their Part D prescription costs until at least the end of the calendar year, even if they lost their Medicaid. The beneficiary's current plan enrollment, their Medicare plan enrollment, will not change if they are in a Medicare Advantage plan or a standalone Part D plan. Part D is the prescription drug plan. Individuals who had Medicaid coverage throughout the PHE but were terminated and are eligible for Medicare now, they have a limited opportunity to access a Medicare supplement insurance plan, also called Medigap, in Pennsylvania. And that's a really awesome opportunity that is available for these individuals. Next, I will turn the presentation over to Susan Neff, the PA Medi Director, to discuss the final remaining topics.
Thank you, Aikisha, and good morning, everyone. As Aikisha mentioned, Pennsylvania Medicare Education and Decision Insight, PA Medi as we refer to it, is part of a national network of state health insurance programs that are funded through a grant from the United States Administration for Community Living, or ACL. Along with ACL, we work closely with the Centers for Medicaid and Medicare Services, or CMS, and the Social Security Administration on the federal level. To carry out our mission at the state level, we work as needed with DHS, Department of Human Services, PA Link, the Pennsylvania Health Law Project, Benefits Data Trust, the Pennsylvania Insurance Department, AARP, and the Pennsylvania Legislature. Locally, PA Medi is housed within PA's 52 Area Agencies on Aging, or AAAs, and has many local partnerships that include service organizations, social service providers like county assistance offices, community health centers, centers for independent living, and others. So how do we promote PA Medi? We accomplish this in many ways. PA Medi provides local Medicare programs and events for the general public. Medicare eligible individuals, their families, and caregivers
that include Medicare 101 presentations, Medicare preventative benefits presentations, extra help and Medicare savings programs outreach. We do presentations about avoiding Part B and or Part D late enrollment penalties. And we also have Medicare annual open enrollment events. PA Medi's events are listed on PDA's website, so you can visit aging@pa.gov and choose the Medicare counseling tile. We also promote the program using traditional media like radio, podcasts, television, press releases, and print media. PA Medi also leverages the power of social and digital media to raise awareness of the program. Although our services are available year-round, most of our outreach is conducted prior to and during the Medicare annual open enrollment period that takes place October 15th through December 7th every year. And it gives our beneficiaries the opportunity to review their coverage and make changes. This is PA Medi's busiest time of the year. During open enrollment period, beneficiaries can join, switch, or drop Medicare Advantage or prescription drug coverage. PA Medi is the known and trusted resource for Medicare information. As a community-based, local network-based health and area agencies on aging, we partner with groups like yours and businesses, government, community, and social service organizations to increase awareness of and promote PA Medi and its services. We attend health fairs, senior expos, legislative expos, and the like to reach as many beneficiaries as possible. There are still many Medicare beneficiaries who do not know about the program. Therefore, outreach is critical if we are to reach those who could benefit from our services. And that's where we need your help. So please let your friends, family, and colleagues know about this useful program. And please also let us know if you have any suggestions for further outreach opportunities. There are many ways to contact PA Medi and get help with Medicare related needs. First of all, PA Medi has a dedicated consumer helpline at 1-800-783-7067, and it's available from 8 a.m. to 5 p.m. Monday through Friday. The helpline assists with information and referral to the appropriate PA Medi program in the local area for further counseling that is based on the caller's county of residence. Beneficiaries can also contact the local PA Medi office that's listed on PDA's website. We also have a listing of all of the local programs over the next several slides. General Medicare help is also available by calling 1-800-MEDICARE or visiting www.medicare.gov. So on the next several slides, we have a listing of the local programs, and we are here to help with all your Medicare questions. PA Medi has an office that serves counties near you in the Area Agency on Aging. So just to wrap up, PA Medi, Pennsylvania Medicare Education and Decision Insight, offers free, confidential, and unbiased Medicare counseling and education to Pennsylvania Medicare beneficiaries to assist in making informed decisions about Medicare insurance coverage. We provide information that helps make decisions and optimize access to healthcare and benefits and cost savings. Our services are available year-round and during the Medicare annual open enrollment period that takes place October 15th through December 7th every year. So please reach out to your local program or us for more information and assistance. So if anybody has any questions, we are open to taking questions this time.
Thank you for the presentation. Any questions from the members? Go ahead, Lloyd.
Thank you. Very good presentation. I remember a program called the Apprise program. Is this basically a replacement for the Apprise program?
Yes, we were rebranded Apprise in 2021. We were aware that the Apprise name had no direct correlation to what the purpose and function of the program was. So it was rebranded to Pennsylvania Medicare Education and Decision Insight, PA-MEDI for short.
Thank you. So my next question is, as a behavioral health advocate, I wonder what you do when an individual with limited cognitive capacity or who shows signs and symptoms of some form of mental illness gets involved with a counselor for getting counseling on what to do for their Medicare programs. How do you deal with that? Are you able to make referrals to other programs for assisting that individual? Just tell me what your protocols are.
Yes, most certainly. Since we're housed in the local area agencies on aging, we have full access to the other services that are provided at that agency, and our counselors are well versed in when it's appropriate to make referrals. We also are open to having that person's designated caretaker or power of attorney attend a counseling session with that individual if that should be the case.
How do you know the counselors are well versed in this? Just wondering.
It's part of the training that we do.
Thank you.
We do a considerable training in soft skills, not just for Medicare counseling, but also, you know, any type of situation that could possibly present himself. We do support our volunteers and staff with those type of skills.
Glad to hear that. Thanks.
Any other questions from the board members or the audience?
Good morning. This is David Johnson. Keisha, Susan, thank you for the presentation. A topic of significant importance to this subcommittee has been the PHE or public health emergency unwinding and the end of continuous Medicaid coverage. Really appreciate you outlining what free and unbiased services are available to individuals receiving LTSS who may be losing eligibility and could potentially want to reevaluate their Medicare options. Outreach and engagement to everyone potentially affected by this process is critically important, and DHS has gone to great lengths in addition to the managed care plans and all the helpers in getting the word out. Does PA-MEDI ever make any proactive outreach to the managed care organizations to perhaps educate or inform service coordinators about the size and scope of PA-MEDI?
We've worked with the Office of Income Maintenance starting about a year ago because we were anticipating the unwinding happening. And we know that our information is printed on the letters that go to anyone who is Medicare eligible of that age. And we are totally open to making presentations to the MCOs, Community Health Choices.
Great, thank you.
Jeff?
It's Jeff from Pennsylvania. So do you do any targeted trainings to groups like veterans or populations, maybe some that are dual eligible and some that aren't, or is the training just all the same?
Well, we do presentations as part of our outreach to veterans groups and to any group at the local level. You know, we do outreach to the different groups, and we also, you know, can do presentations to specific groups. I know for a fact that we have worked with many veterans organizations about coordination of benefits and things like that. And we do outreach at the statewide level too.
May I jump in there? Did you also mean training to our PA-MEDI counselors and volunteers on subgroups like veterans?
It could include the
Okay.
if you adjust any of the trainings just for folks that are dual eligible as compared to folks that are just traditional Medicare enrollees or things like that. So just how how Medicare works with the other specific pockets or, we'll say Medicaid or other supports that somebody might have? Thank you.
Okay. Yes, Susan, I could keep going, take this one. Yes, we do provide ongoing training throughout the year, virtual or in person as that may be allowed or available. And that could include teaching our counselors about veteran services. That could include, and it has, teaching our counselors and our volunteers about managed care organizations or CHC. And we do a variety of different topics. We keep our eyes and ears out on different listservs and websites to find out what's important, what's relevant out there. And then, of course, as we were just talking about earlier, because of the population that we serve can be very diverse and could have many needs, many circumstances, we try to be as trained as possible. Maybe we're not experts in Medicaid, like, the income maintenance office, but we try to know a little bit because we just don't know who's going to call us, who's going to walk through that door. And we want to know at least a little bit about the different populations and the different resources out there, because you guys probably are familiar with No Wrong Door, but we do that particular, policy, but we adhere to that. So we try to help get people wherever they need to be, in addition to Medicare counseling, if that's what they need. So, yep, we provide training for lots of different things all the time. Thank you for that question.
Thank you. Paul, is there anything in the chat?
No, Mike, there isn't.
Thank you. Any other questions for TA Medic? Thank you both for the very comprehensive presentation. We thank you, and we have numbers if we need to get a hold of you. So let's move on our agenda. Next up is the Financial Management Services Tempest update. Larry Spencer and Garrett Beauregard. Yep. Take it away.
Good morning, all. My name is Larry Spencer. I'm the CEO at Tempest Unlimited. Happy to be here with a number of members from our team to present some information and to answer some questions. And I'll turn over to Garrett Beauregard. Garrett?
Garrett, if you're speaking, we can't hear you.
Garrett, this is Paula. Are you able to unmute? I show that you are self-muted.
I just shot him an email, so.
I'm on, trying to get unmuted.
There you go.
Can you hear me?
We hear you. Yeah,
there
we hear
we
you.
are. All right, thank you very much. Sorry about the problems. This is going to be one of those days, I can tell. So thank you, everybody. I know there are 2 agenda items on this. It's really just going to be one presentation, the MCOs and Tempest working together. So we do have Larry introduce himself, and then we have representatives from the 3 MCOs, including myself. I'm Garrett Beauregard. I'm with UPMC, and I'll be presenting on behalf of the MCOs. And we will have a Q&A session at the end here. This may be a little disjointed today. One of Tempest's presenters was unable to make it. She had a death in the family last night, and we're having troubles getting so that she can present that part. So we're just going to play it by ear just a little bit here. So this is our agenda here on the screen. We're going to start off just kind of talking about the transition and what the expected outcomes were and what we think we've achieved. And then we'll go into the call center, talk a little bit about performance there. We'll talk about just general payroll activity, talk a little bit about enrollment activity and how that has progressed since, in the year since we've gone through this transition. We'll talk a little bit about the satisfaction survey, and at the end there's an item about EVV as well before we go into Q&A. So next slide, please. So we thought that it might be worthwhile just to start off and talk a little bit about the transition, which literally happened a year ago, a little more than a year ago, July 1st of 2022. And at the time, even before the transition, when we announced that the MCOs were going to take over the responsibility for the FMS, we talked about what the benefits would be, and this is really a list of what we believe we've achieved. Right, we've eliminated the overtime authorization, which in the past had been a real problem from an administration standpoint in ensuring that people were paid on time. We have seen really great payroll performance, timely payroll payments. Direct care workers are actually paid a week earlier than they had been in the past, just because of the way the process works with Tempus. We've enabled very strong collaboration between the managed care organizations, HHA and Tempus, and OLTL. We still meet every other week with OLTL to review FMS activity and other items, and try to stay in lockstep so that the FMS function is working very well. We have very strong and timely communication between Tempus and the MCOs, HHA as well. They're the system operators, to make sure that enrollments are going well, payroll is going well, to deal with any type of escalations or problems that pop up. We have seen better communication to the common law employers and direct care workers working through Tempus with their RAVE messaging system, and also the MCOs driving letter campaigns out to CLEs and their direct care workers. We believe we've got better management, budget management support from Tempus, helping common law employers stay within their budgets to ensure that they don't run out of budget and therefore services early. We are working through the Ops 38. We've made Ops 100 was transitioned to Ops 38. We made some updates to that Ops 38 report, and working with Tempus, the MCOs are reporting that and delivering consistent performance and meeting the metrics set forth for us. We have much closer EVV oversight now, working with HHA and Tempus there. And then probably one of the most important things is that we really delivered continuity from the transition, before transition and post-transition, with Terry Reeser, who has been involved with the PA FMS activity for many, many years. So next slide, please. We're going to move to the call center, and I want to introduce Mia Deal. I hope Mia's been able to join the call here. She manages the call center for Tempus, and she's going to talk about the great success we've had with the call center here. So Mia, are you on?
I am. Can you hear me?
Yes, we sure can, Mia. Go ahead.
Okay, perfect. Okay, good morning. My name is Mia Deal. I am the Consumer Relations Supervisor, and I have assisted with supporting and leading the Consumer Relations Department within the call center, answering any and all payroll inquiries. And I am calling in, so excuse me with the slides. I do have them up in front of me, but bear with me. Based on the numbers from the beginning of the transition to just a couple months ago, there was a great improvement with call support and call handling, and information that we overall, just everything with our communication base. Does anybody have any questions on the numbers or what they see here?
We'll do questions at the end, Mia. You can just go ahead to the next slide.
All right, so we can go to the next one. So this does include EVV support and enrollment. We have increased our numbers since the beginning of the transition to support these calls, which has, shown a lot of improvement in the team and the overall support of the calls. And our next slide for the call center, historically from the beginning of the transition, we had a large amount of reps, just about 100, just under 100. And a good amount of the representatives that we had showed a lot of potential and knowledge of the program to support the calls, from whether they were temp to permanent or permanent. We have a very strong team that supports the calls daily. We've reduced a lot of call volume. This is with enrollment issues that we did experience, and as well as the EVV, which has been corrected. And we have, again, a lot of improvement here. We currently have staff that can flex their support within the department to support PA. So our call center metrics and call volume, we have a various amount of wrap codes that we use to kind of determine what the calls are and how we are, what we are supporting throughout the day or month to month, how issues do change and fluctuate.
Next slide, please.
Okay, so I can't see it. So where are we right now?
We're on the call center, the wrap code slide, Mia.
Okay, the wrap codes. Okay, perfect. So the wrap codes are used to indicate what calls we are getting or receiving and what we're supporting specific to like period or month to month. This gives us a better idea of what we can retrain or provide to the staff that are handling the calls. This improves knowledge that we provide to program members that call in on a daily basis as well.
Next slide, please. Thank you.
So this shows.
We now see the pie chart, Mia.
Okay, perfect. Thank you. So this slide shows the volume of calls and what we see that comes in, more frequently. So it's payment issues have decreased drastically. But we are still supporting a good amount of those calls, and just EVV issues as well have decreased from where we were to current.
Did we lose you, Mia?
I lost my entire the whole pie chart. I just lost it all. 1 second.
No worries. I'll take it from here, Mia. Thank you. Thank you very much.
Thank you.
So just to finish this up, the MCOs see this pie chart right now on a weekly basis. We're probably going to cut that back to probably monthly here soon. And we just track the reasons for the calls that come in. And yeah, very traditionally, it's payment and enrollment that kind of bounce back and forth between each other. The number of calls around EVV has definitely dropped. And so we use this as a tracking item to see what folks are calling in about. So next we're going to move over to payroll, and I believe that's Laura Fraticelli. Laura, do you want to introduce yourself and cover this slide?
Hear me? Hello?
Yeah, a little light.
Yes, we can hear you, Laura.
A little light, but yeah, we can hear you.
I'm so sorry. Is this any better?
That's better.
Much
Thank
better.
Okay. Hi, everyone. I am Laura Fraticelli. I am one of the assistant FI directors here at Tempus. I will be reviewing the next few slides for you. So this is just an overview of our payroll. We had, sorry, let me just go to the right slide on my own notes. So the current slide shows the total number of DCWs and number of checks and direct deposits that were issued in the time frame of August and September, January and February, and May and June. So as you can see, for May and June, we issued direct deposits and checks to 10,380 DCWs, and issued 52,296 checks. So our numbers have been pretty steady, but we have seen a slight decrease in the number of DCWs who have been paid from the August-September timeframe to May and June. We also issued 9,237 Act 54 checks and direct deposits to DCWs, and that totaled 9,458. For the Act 54 payments, we worked with OLTL, the MCOs, and even the prior FMS in order to calculate all the information and make the payments out to those DCWs. Next slide. For enrollment for the CLEs, the process for the participant and CLE enrollment process is as follows. Tempus receives the referral from the service coordinator or the MCO. We complete the new CLE enrollment packet, and Tempus will then follow up with the CLE and DCW if there are any items that are not completed. The authorization provided to Tempus from the service coordinators and the MCO for the services at that point after the enrollment package is completed, and then notification is sent to Tempus or from Tempus that the CLE enrollment process is complete. So we will contact the participant in CLE that the process is complete, and we notify the MCO, and then a welcome email from Tempus for the EVV, for the EVI portal and participant dashboard is sent to the participant in CLE in order for them to log in. Next slide, please. At the same time that the CLE is going through their enrollment process, the DCW is also going through their own enrollment process. And this is both for new DCWs of new CLEs and participants, but also new DCWs of existing participants in CLEs. So the process is as follows. The start of the enrollment process with Tempus is typically an over-the-phone enrollment with the DCW, or the DCW and CLE can complete a DCW application request form and submit it to Tempus. Once that over-the-phone enrollment or application request form is completed, Tempus will then complete a new DCW enrollment packet and send it to the DCW. I did want to just add in that both for the CLE packet and the DCW packet, they can be completed electronically via our paperwork application, and so everything can be signed electronically. There's no need for physical mailings and physical signatures unless the DCW or CLE cannot sign electronically. So once the DCW completes their enrollment packet, it is sent back to Tempus. Tempus will then follow up with the CLE and DCWs if there are items that are not completed. Tempus will then complete the required background checks, and we will review those background checks with the CLE as needed if there are any findings. At the same time, the DCW would be working with Frontline to attend a pre-service orientation and training. And the DCW also will have to obtain their Keystone Key and Unique ID. Notification from Tempest that the DCW enrollment process is complete is then sent to DCW and CLEs, and the welcome email is sent from Tempest for the EVI application and EVI portal for the DCW to start working and punching their time. And then the authorization to start working as scheduled by the CLE notification is sent. Next slide. So here's some enrollment statistics for participants in CLEs. The total participants in the program as of May 31st, 2023 is 8,732. The number of new participants enrolled in the program for the first 5 months of 2023 is 377, and the average time from referral to becoming active is 25 days. The most common delays for a participant CLE new enrollment is the participant deciding to stay with the agency, difficulty with finding DCWs, the CLE having an existing EIN, which is the employer identification number, difficulty completing paperwork and unable to complete the paperwork electronically. Statistics for the DCWs is as follows. Total DCWs active and being paid as of May 31st, 2023 is 10,383. The number of new DCWs enrolled in the first 5 months of 2023 is 1,255. Average time of referral to active is 28 days. The most common delays for DCWs being set up and completed is the unique ID not being obtained, the pre-service orientation not being completed through Frontline, and difficulty completing paperwork or unable to complete the paperwork electronically. Next slide. Tempest recently sent out our annual satisfaction survey. The surveys were sent out to all current participant CLEs the week of May 1st, and were due by July 1st. So I think that was last Saturday. Surveys could be returned by mail, fax, or completed online. Reminders to complete the surveys were sent out every other week through 6/26. And then as of 6/26, we had 18% response rate, which is 1,580 surveys had been successfully returned. Tempest is compiling the results as we speak, and we'll be sharing that information with the MCOs by August 1st. And then ongoing surveys will be sent annually to all participant CLEs at the beginning of the calendar year. In addition, new participant CLEs will receive a survey the month after their first paycheck, the first paycheck to their DCWs is sent. Next slide. Garrett, I think I'm passing this over to you.
Yes, ma'am. Thank you very much. So we just thought we'd end here with a little bit of talk about EVV and EVV compliance. You know, the first question to answer is, what is EVV compliance, right? It really happens 2 ways. The shift is entered or punched on the EVI app at the time of check-in and check-out. That means when they start their shift, they punch in, and when they end their shift, they punched out. Or they can use the phone-based IVR and enter again using a landline phone. That is a requirement in the 21st Century Cures Act. And again, it must happen at the time of the check-in and check-out. Any shifts that are entered after the fact, and that's a manual entry, are not considered compliance. Right now, EVV compliance is an opportunity for us. We are below the 50% compliance rate, somewhere around 35% across the entire population. And this is a topic of current discussion between the MCOs, Tempest, HHA, and OLTL, is to look at how can we improve that level of compliance. So we have started with messaging, and there will be letters that will be going out here pretty soon to the CLEs to remind them that EVV compliance is a requirement of the program. And we'll be reminding folks that training sessions are available, that Tempest is available to help anybody with EVV training, so make sure that they have access to the app, make sure that they know how to use the IVR. And my guess is that is a long-term program for all of us to drive that compliance. It's important. It's a requirement of the MCOs. It's a requirement of OLTL in the waiver, I'm sure. And so it's something that we need to stay on top of. With that, let's go to the next slide, and it's time for questions.
Thank you for the presentation. Questions from the committee members? Jeff?
Yeah, this is Jeff again from Pennsylvania still. Can you repeat the total number of consumers and in the program currently, and also note how many are self-directed? Thank you.
So I don't have total number of participants in CHC. In terms of those that are actively self-directing right now, which we define as common law employers that have direct care workers that are getting paid, that number is 8,732. That's on slide 12.
Other questions from the committee members or the audience? Go ahead, Allie.
Hi, thanks. This is Allie Cromley with the United Home Care Workers of Pennsylvania. So we represent 10,000 caregivers in the participant-directed model. So thank you guys so much for this presentation. Just totally appreciate the numbers and the transparency. I think like our allies in the disability rights community, we really strongly support this model as the one that provides sort of the most opportunity for independent self-determination and community inclusion, which is, I think what we would agree is really the goal here. So mostly just, strong appreciation for sharing the data. I think this might be a question for Garrett. It's about the enrollment statistics. It's maybe similar to the other question asked, but I'm just looking at the slide that says enrollment statistics. So the total number of CLEs enrolled in the first, I guess, January through May is 377. How does that compare with the total number of CLEs who enrolled, through agency care in the same period of time? And I guess, how does that number compare are there historical numbers there as well? Like the first 6 months?
Hey, Allie, it's Garrett. I don't have numbers either system-wide or for UPMC to indicate the number of CLEs that selected agency or use a combination of the two. I don't know if anyone from PA Health and Wellness or AmeriHealthcare Tusky Stone First wants to volunteer any information that they may have.
We had someone coming up.
Garrett, it's Frank Santoro from our Healthcare Talks. I don't have those stats available either.
Hi, Garrett. This is Joe Elliott from PHW. I don't have those numbers at my fingertips either.
Thanks. Sorry, Allie. We've been really focused these last several weeks putting together this presentation, very much focused on the FMS activity, and really didn't think to look at a broader picture like that.
No, that's cool. I guess I would just say it would be interesting to understand that in large part, just sort of to understand the degree to which I think participants are sort of effectively educated about the choice of participant direction and making sure that they have the, that option presented to them and explained to them throughout the system. So I think that would just be interesting to understand. And then.
Yeah, I can just briefly on that, Allie, from a UPMC standpoint, I can tell you that we've put together a pretty comprehensive training program around self-direction for our service coordinators, and I am absolutely certain that this option is always presented to participants, particularly as they enroll in CHC, and they're seeing all this for the first time. I know Mike Smith from UPMC is on. I don't know if he's got the ability to unmute, but he may want to comment on that too, or Frank or Joe, or Angela, if anyone else wants to comment on that particular aspect.
Garrett, I'm not sure if you can hear me. Folks hear me?
Yes, I can, Mike.
Yeah, so yeah, we do quite a bit of training. It's actually something that's required that on top of it that we do every time we update a care plan, and we're looking at working with a participant around their services. So this option is regularly provided and available, and we're also looking, as I said in our comments to a previous question about expanding the network, we're really looking to place a heavier emphasis on consumer-directed model moving forward as well. So we do quite a bit of education in our weekly updates, our newsletters to staff, as well as regular trainings on this that we conduct with all of our service coordinators to educate consumers, participants.
Thanks for that.
Garrett, this is Frank Santoro from our Health Caritas. We have a similar training program for our service coordinators. And when presenting different models to our participants, we do present the participant-directed model of care first to our participants.
Hi, this is Joe from PHW. We're very similar. We have extensive training models for our service coordinators, and similar to what Frank mentioned, when we do offer different service models, the participant-directed option is offered first.
Thanks.
Thanks, everyone.
Any other questions on Tempest and the presentation? We have somebody come.
Hi, my name is DJ Weber from Angels on Call, and I'm also the president of the Home Care Association. And you might have said this, but what is the auditing process for Tempest? Do they go through similar audits to other home care providers? And what, the 35% EVV compliance is obviously below 50%, which is the standard. So what sort of plan of correction or corrective action plan is being taken for that?
Tempest is not a home care provider. They're the fiscal intermediary working under HHA as the financial management services vendor.
I understand that part, but you still employ direct care workers, or the consumer employs direct care workers. So what sort of auditing takes place for the personnel files and things and billing and things like that?
I guess I don't really understand your question. Tempest does not employ any direct care workers. They are the fiscal intermediary. They make payment on behalf of the CLE. If you're asking about information security, each MCO has a contract with HHA that has probably inches of paperwork involved around information security. And then that is a flow down requirement through HHA to Tempest. And HHA gets audited on a yearly basis, as do all of our vendors. Speaking specifically for UPMC, I can say that. And I invite Frank and Angela and Joe to represent themselves.
Okay, that's helpful. So then perhaps you can't answer this question, but for the 35% EVV compliance, then who is held accountable? Is it the direct care workers, or is the participant or HHA exchange questioned about people who are not EVV compliant?
That is a complicated one, and one we're currently discussing. So the direct care workers are required to maintain a minimum 50% compliance rate. The CLE is their employer, and so they are also responsible for ensuring that their direct care workers achieve that, since the MCOs are also own a compliance requirement for both agency and self-direction. We also are on the hook to do that. And so that's a reason why we continue to work with OLTL to look for ways to drive that compliance rate.
Thank you.
And again, Frank, Angela, Joe, I invite you to add to that if you feel you have more info.
No, thanks, Joe. Garrett, I think you answered it perfectly. We would agree.
I agree. Also, Garrett, thank you.
Any other questions? Go ahead, Ally.
Yeah, this is Ally Cromley again. I'm just thinking about that discussion. So our understanding is that on the provider side, that the agencies receive a value-based payment if CVV numbers reach a certain percentage of compliance. And one of the things that we've been advocating for is replicating some of those value-based performance metrics on the participant-directed side. So just as we're thinking about opportunities to expand CVV compliance, one of the things that we'd like to recommend or throw on the table there is thinking about how a similar kind of financial reward that goes to providers for hitting benchmarks can happen on the participant-directed side. Not sure if folks are thinking about that or have any reaction, but reflecting on this conversation.
Yeah, Ally, I think we've kind of looked at all opportunities. Making payments directly to recipients is really muddy waters. And so I don't know, Randy or Kim, if you want to talk about, what the world of value-based payments to DLEs or their DCWs looks like.
Paula, is there anything in the chat?
Okay, it's not necessary. Thanks, Garrett.
You're welcome.
Yeah,
We can also do the following too, Al.
Sure.
We have a few questions in the chat. The first question comes from Pamela Watts. Question for Tempest regarding the slide on transition overview. Can you explain what elimination of overtime authorization means?
Sure. This is Garrett again. So prior to the transition, there were two separate codes in the CHC benefit grid. One was for regular time and one was for overtime. And the MCOs were required to send in authorizations for both regular time and for overtime. Big issues arose because we really don't have clarity on exactly how the services are going to be used. And let's just make a pretend example. Let's say that Mrs. Jones is authorized for 65 hours a week for her services. We don't really know from week to week whether one direct care worker is going to work all 65 hours, which would mean then 25 hours of overtime, or perhaps she's going to have two direct care workers who are going to split that. Perhaps one's going to work 40 hours and the other's going to work 25 hours, so no overtime is incurred. When that happened, the previous FMS, there was a pretty torturous process to go back and update the authorizations and move time from one to the other, which created long delays in being able to accurately pay the direct care worker for the time that they worked. By eliminating the overtime, and this is a decision that all three MCOs made jointly, by eliminating the overtime authorization, we simply said if the worker works that overtime, we're going to pay it. And so it really enables Tempest to process the payroll quickly, efficiently, and on time, so that, again, the participant, the CLE, are in charge of their services, in charge of who works what and how many. They're given a budget. They need to stay within that budget, but how they utilize that is up to them. So it really sped up the process of ensuring that the direct care workers got paid what they worked and getting paid on time. Does that help? Or I hope it helps them.
Thanks, Garrett. This is Shanrika Pine. This question comes from Pamela Watts. For Tempest, can the DCW start providing services while waiting for their enrollment with Tempest to be completed?
This is Garrett again. I can take that. We had that discussion with OLTL, and the decision was made that the direct care worker needs to get completely through all of the enrollment activity before they can be considered authorized to work.
Thanks again, Garrett. This is Shanrika again. This comment is from Elizabeth Barna. She wanted to make the comment that surveys were not received by all CLEs.
So, Laura Fraticelli, you may want to chime in if you're still on, but surveys were sent out to all CLEs, both by email and then by printed letter to the address on record. If someone did not receive a survey and would like to complete one, I would recommend that they call Tempest and ask for a copy of the survey to be sent to them and just confirm either an email address or a mailing address. As we said, the survey has closed, so that would need to be done very quickly so that we can pull the data together and have it ready for the MCOs and ultimately OLTL by August 1.
Yeah, Garrett, this is Laura. Thanks. That's exactly what I would like. I'd love to know, be able to research to figure out what the barrier was. Was it that we had old or incorrect contact information, or is there something else?
Thanks, Laura. And we always encourage people to check their spam folders or their deleted folders. And that email, Laura Fraticelli, did that email come from a tempistunlimited.org email address? Was your email out? Do you remember?
Let me look to see if I can get that. I remember it was a few months ago when we put this together, so I can look to see if it was coming from ours. I think it actually came from a third party because we use SurveyMonkey.
SurveyMonkey.
But we are looking into being able to send it directly from our tempistunlimited.org email. So hopefully in the future.
Great. Yeah, good reminder that definitely encourage people to check their email, their inbox, their spam folder, their deleted folder, and look for something from SurveyMonkey, 2 words, SurveyMonkey, and that would have the survey from Tempest.
Thank you. Shanrika again, this question is from Quintanilla Hicks. Aside from mail notification, what other measures are being taken to assist home care agencies with HHA noncompliance with EVV?
Are we referring to agencies or are we referring to self-direction here? It sounds like that's an agency question, which really isn't the topic for this agenda item.
We'll ask for clarification.
Thank you.
The next question is also from Quintana Hicks. We were informed that home care agencies can terminate problematic aides that do not comply to EVV rules and regulations, and the MCO will track the aide if they transfer to another home care agency. Wouldn't this be problematic for home care agencies that are losing all of their consumers because of problematic EVV issues?
Yeah, again, this is referring to agency, which is outside of the scope of this agenda item. I don't know that anyone's prepared to discuss that topic.
Shanrika again. This question is from Carolina Belusco. Is the self-directed consumer subject to any audits from MCOs? Who determines the ability of consumers to direct their own services? Is there criteria that needs to be met for that?
So the discussion, and again, I'm going to encourage Angela or Joe and Frank to jump in here, but the decision to select to self-direct one's services is done between the participant and the service coordinator long before, or at least before, HHA or Tempest get involved. It is the consumer's or the participant's choice to select self-direction. There can be cases where there is an obvious need to have a representative CLE involved, which can happen with, intellectual disabilities, behavioral disabilities, or other things. But that is an option, so that a participant would like to self-direct their services. They can nominate someone to be their representative CLE who effectively becomes their, I like to call it a general manager for them to manage their employees. Tempest does not make a value judgment in this sense. When they're referred, they will enroll that person. If they run across a situation where someone just fundamentally does not understand what's going on, they may refer back to the service coordinator and ask the service coordinator to get engaged and see if maybe we should look to see if we can find someone to be the CLE on behalf of the participant. But Tempest does not make a choice to allow someone to use self-direction or not. And Frank or Angela, would you like to add to that?
Hey, it's Frank Garrett. I concur with you. I mean, a participant is able to nominate or appoint someone to be their CLE if they do not feel they have the capacity or even desire to be the CLE.
Yeah, I'll just state agreement there. Our service coordinators would help to resolve barriers, but otherwise, Tempest would not be making those decisions.
Thanks, Angela.
Thank you. We have no additional comments in chat at the moment.
Thank you. Are there any other questions from the committee members for Tempest, the FMS, and for any of the MCOs? All right, well, thank you all for the presentation. We do have some follow-ups that we'll be doing as well. Right now, we'd like to move to the next item on the agenda, which is the additional public comment portion of our agenda. And I open up the floor.
I just want to make sure that I haven't been here the whole time. My name is Pam Auer. I'm the Center for Independent Living with Central PA, and I'm a member of PA and want to always be saying as clearly as I can that we don't support assisted living in the waivers. I'm sorry to be discussed a lot today, but I wanted to make sure that I had that on record, especially in doubt. So thank you.
Who's next? Paula, please let me know if we have things in the chat too as well. Go ahead.
Is this just for the committee, or can I ask some questions too? Okay. So my first question, and again, I'm CJ Weber, I'm from Angels on Call, but also the president of the Pennsylvania Home Care Association Board of Directors. My first question is, we have a lot of participants that seem to be on vacation this summer, more than ever before, which totally on board with that. I believe that everybody deserves to get some time as well. But a lot of their caregivers don't like to use EVV. And when we ask if we can add a second address to HHA Exchange, they say, well, we're not always going to be at the house, which, again, I believe in independence and that you should be able to do what you want on vacation, but I also worry about the participants not being able to get the services they need to sustain their activities of daily living if their family member is taking them to, you know, all different places while they're on vacation. When we have spoken to some of the specific service coordinators about it, they say, well, that's the agency's choice and you guys can do what you want. But then, of course, I worry about the operational side, the billing, the liability, all of the things. So I was just wondering if the three MCOs could possibly weigh in and give us some guidance on what kind of policies that we could write to maybe protect ourselves and also make sure that we are giving participants the independence they deserve.
Great question. We'll open up the floor to the MCOs to respond.
Hi, this is Joe with PHW again. At this point, it's really up to the participant if they want to take a vacation. We don't have a specific policy that would limit the ability of a direct care worker to travel with the participant. Although I do believe that the MCO would only reimburse for the actual caregiving time up to the authorization that had been provided, so would not reimburse for any of the other time that the caregiver may be with the participant that they're not providing care.
Thank you.
Yeah, this is Mike Smith from UPMC. I would agree with Joe's statements. I would only add that for agencies, they need to consult their legal counsel regarding, you know, any kind of concerns that they may have about the out-of-state travel and how that would be handled within their own organization.
Go ahead.
Hi, this is Misty Weekland with American Healthcare Talk Keystone First. I agree with both Mike and Joe. We do not have any policy that would prohibit direct care workers from going on vacation. As Joe mentioned, we do pay up to the authorized amount. We have had on occasion participants asking for a temporary increase just because of some additional needs they may have while on vacation. Those have been approved. And Mike did give some good advice for the agencies to check with their legal counsel. Many of our participants travel out of state to go on vacation. Just want to make sure that there are no prohibitions with their payment if they are working out of state. But from our end, it is approved.
Thank you. Good morning, John.
Good morning, Mike. I come to this table wearing two hats because as a consumer of services who goes on vacation, who wants to continue to go on vacation, the question is difficult because I want to say we all have a right to go on vacation. And, you know, whether or not
I think each circumstance needs to be worked out by each provider. And the consumer shouldn't be prohibited from that vacation opportunity. Also, I think that as a provider, the way that we have dealt with it is that, you know, the vacation location is often identified prior to, and where they get up in the morning and where they go to bed at night, that address can be added. And what they do in the day really, you know, is theirs to manage as long as they stay within their authorized hours or approved hours. And I just think that this is a conversation that, you know, if when people don't have a disability, they don't have to get permission to go to the beach and then to a restaurant and then to a show, but people with disabilities do. So the way that we handle it is that the address where they sleep is the address that we put into the EVV system. And that at least gets us close. And the rest, when I'm audited, I'm gonna fight, because everybody has a right to go on vacation. So I guess that's my 2 cents. Thank you.
Thank you, Shauna.
And I totally agree with Shauna. I think we wouldn't have been having this conversation prior to EVV, because I remember back in the fee-for-service days, if someone went on vacation, we were like, cool, we're gonna service you within the authorized amount of time. We'll make sure that we have documentation, you know, for time, scope, and duration, and have a great time. But now with EVV, it just adds a different layer, which, again, agree with, you know, EVV for all intents and purposes. It just makes it more complicated when you're worrying about that, and also the liability. So thanks about the legal advice. We will definitely consult our counsel on that. This one is the easy question, hopefully, and it's for Bear Health. I was just wondering if we have an update on the scorecard for the Open Arms program, and if that is coming out soon, or if I perhaps missed it, where we can find it.
Hi, it's Frank Santoro. Who asked that question? We have distributed the Open Arms, so I can certainly get that to you or your account executive.
Hey Frank, it's CJ, the president of the Home Care Association, and also with Angels on Call. I have the program. I just know that it had mentioned in the program that there was going to be a scorecard, and I think when we talked at the conference, you said it was going to be sometime in June. So I did reach out to my account rep, but I haven't heard back yet. And I have, you know, my boss is anxiously awaiting the scorecard, so I figured I would bring it up here to see if we had an update on that.
Sure. Certainly send me your contact, or I'm assuming you can send me an email, and we can get that to you if your account executive hasn't been able to do that for you.
Thank you.
Thank you.
Who's next? Any additional public comments from any of the board members? Go ahead, Jeff.
Not on. Yeah, do we have any update on agency with choice at this time?
This is Juliet. We are still waiting for the Pennsylvania courts. So no updates at this time.
There you go. Thank you.
Other questions from the board members or the public?
We do have a question in chat.
Okay, go ahead.
This question is from Carolina Belusco. Are there any travel limitations for going outside the country when the consumer travels with a DCW?
MCOs?
Well, this is Juliet, and we can certainly get back to Carolina with an expanded answer. But generally speaking, Medicare and Medicaid do not provide services for out-of-country travel. But we'll certainly get back to you with a more expanded response to your question.
Okay, thank you. Other questions, comments, audience, board members? Hearing none, I will request, make a motion for adjournment. It looks like I might have a second, Lloyd. If you can confirm that on the mic. Confirm. All right, thank you. Our next meeting will be in person here on August 2nd. Same time at 10 a.m. So I thank you all for your participation today, and I look forward to our next meeting.